Hi, my name is Dr. Jones. I'm a resident in the preventive medicine program on the complementary pathway, and I'm going to talk today about coding for point-of-care ultrasound for abdominal aortic aneurysm screening. During this short presentation, I'm going to discuss what to review in the patient's history. I'm going to discuss ICD-10 coding specific to abdominal aortic aneurysm, CPT coding for the same, some counseling codes that can be used, and I'm going to use an example for you to follow. It is important to check the patient's history regarding prior screening for abdominal aortic aneurysm, as the screening test only gets paid for once in their lifetime. So it is important to ask the patient about any prior imaging they've had of the aorta. Some might know, some may not. You can look through the patient's record in the EMR system or in the paper chart if you still have those. See if any prior imaging has reported on the abdominal aorta. You can also check prior echocardiogram reports, prior cardiology consult reports that may comment on this, and vascular surgery consult reports. The American College of Radiology has established some ultrasound screening examination requirements when being performed for an abdominal aortic aneurysm. Again, this is specific for screening. Requirements are quite simple in that longitudinal and transverse images are required in 3 locations. The first is proximal, just below the diaphragm near the celiac artery. The second location is considered mid, near the level of the renal arteries. And the third location is distal, which is just above the iliac bifurcation. Again, transverse and longitudinal images at each of those locations. If an aneurysm is present, it is measured in its greatest dimension, and that is in the centimeters that's reported. If no aneurysm is identified, the largest diameter of the abdominal aorta is reported in centimeters. When interpreting the point-of-care ultrasound screening of abdominal aortic aneurysm, it is important to report if the exam falls in one of 3 categories. The first category is a positive finding, in which the infrarenal AAA is greater than or equal to 3 centimeters in diameter, or is greater than or equal to 1.5 times the diameter of the more proximal portion of the infrarenal aorta. The next category is considered negative, in which no infrarenal abdominal aortic aneurysm is noted. And the third category is indeterminate, in which the aneurysmal status is not clearly defined because of non-visualization or partial visualization of the infrarenal abdominal aorta. So again, the report should specify one of those 3, either it's positive, negative, or indeterminate. The American College of Radiology also recommends that the report state whether or not the suprarenal aorta was noted and whether or not it is normal. The report should also state whether the dilatation of the aorta above the celiac artery is noted as well. The specific reference for this information is noted at the bottom of the slide. So once you decide you're going to do abdominal aortic aneurysm screening, it is important to choose the correct ICD-10 code for this. Some third-party payers are particular about what ICD preventive medicine code is used. Your best bet across the board is using the Z87.891, which is a personal history of nicotine dependence. If other smoking ICD-10 codes apply, you can use those as well. The code Z13.6 encounter for screening for AAA often is not covered, in my experience, although some insurance carriers will cover the V81.2 code, which is a special screening for abdominal aortic aneurysm. Just to make sure it is paid for, you may want to use more than one code as applicable. Again, the codes mentioned in this slide help justify a preventive screening, not a diagnostic screening. For diagnostic screening, other codes that specify that they already have an abdominal aortic aneurysm or thoracic aneurysm, iliac vessel aneurysm, and so forth would be more appropriate. It seems like codes are forever changing, and in regards to CPT coding for AAA screening, 76706 is the current appropriate code, which is for ultrasound of the abdominal aorta, real-time with image documentation screening study for AAA. The previous code of G0389 was phased out in 2017 and should no longer be used. Other ultrasound codes should not be used for screening, just the 76706 number. However, if diagnostic imaging is performed, other codes other than this should be used. If you're coding for this in the office and you're just coding for the professional component only, you use a modifier 26. If you're just charging for the technical component, which means you did the study, but you're not providing a report, then you use modifier TC. If you're performing the test and providing a report both, that would be a global fee, which may or may not need a modifier 59 code. I would recommend using the modifier 59 code, as it indicates a distinct procedure independent from any other services that are performed on that day in regards to E&M codes and other CPT codes. Again, it is important to remember that only one screening will be paid for a patient in their lifetime. Some references on where I obtained this information can be viewed at the bottom of the slide. To maximize appropriate coding, I've also included a few counseling codes. The first is G0446, which is counseling for cardiovascular disease of approximately 15 minutes. This can be used for any purpose, and certainly counseling the patient about the abdominal aortic aneurysm screening, this would be appropriate. Reimbursement is generally not good. It's probably $6 to $10, but it may help achieve meaningful use as determined by Centers for Medicaid and Medicare. Other codes that can be used that pay slightly better is 99406 and 99407, which are smoking cessation counseling. 3 to 10 minutes for the 406, and more than 10 minutes is the 407. Again, these codes can help achieve what they call meaningful use with the Centers for Medicaid and Medicare and improve your reimbursements overall. The sources I use for this are located at the bottom of the slide. Here's an example of what a patient's billing sheet might look like with an I-10 for essential primary hypertension, using a V81.2 code for screening of the AAA, and another code, the Z87891, for personal history of nicotine dependence. You can use both of those codes together. Whenever you use several codes, you always try to use your preventive medicine codes as the non-primary. Always use something else as the primary. Then when you look at your CPT codes, if you're counseling regarding the cardiovascular disease, you include the G0446. If you're counseling about smoking cessation, here, say, for example, you can use the 99406, but notice I use the counseling code for 99406, but at the top, for the ICD-10, I just specified history of nicotine dependence. So it'd probably be more appropriate to use an F code, like a F17210, to specify that they're dependent on nicotine. It would be more appropriate in this particular case. And then the last CPT code you see there is 76706 with the modifier 59 as a separate identifiable code there, showing the ultrasound done in the office with interpretation. And then your level of visit would be the 99214 usually with a 25 modifier code. I am not a certified professional coder. I'm a physician, and I would always recommend that before the codes are sent to a third-party payer, these are always reviewed by a professional coder to ensure accuracy. So to summarize what we've talked about today, it's important to review the patient history and see if they've had a prior screening for abdominal aortic aneurysm, as this only can be paid for once in their lifetime. Next thing we discussed was ICD-10 coding. The biggest one to remember there is the Z87891, the personal history of nicotine dependence. The only CPT code you really need to use is 76706 for screening. Again, if you're doing diagnostic, none of these codes would be appropriate. You need to use different codes. But specifically for screening, 76706 is the code to use. And we discussed some various counseling codes that may help improve your reimbursement. And lastly, we showed an example on how to do coding for a patient. I hope this answers any questions. And please feel free to contact me at jonesmd@hotmail.com if you have further questions. Thank you.